Welcome to the AOA Future in Orthopedic Surgery podcast series. This AOA podcast series will focus on the future in orthopedic surgery and the impact on leaders in our profession. These podcasts will focus on the vast spectrum of change that will occur as the future reveals itself. We will consider changes as they occur in the domains of culture, employment, technology, scope of practice, compensation, and other areas. My name is Doug Lundy, host for this podcast series. Joining us today is Dr. Scott Porter. Dr. Porter is an orthopedic oncologist and vice chair of operations in the Department of Orthopaedic Surgery at Prisma Health in Greenville, South Carolina. He completed his internship and residency in orthopedic surgery at Carolinas Medical Center, his fellowship in musculoskeletal oncology at the University of Chicago, and his MBA from the Kellogg Business School at Northwestern University. He's a director of the American Board of Orthopedic Surgery as well. Dr. Porter, welcome to the podcast.
What's going on? Thank you for having me.
And as y'all couldn't tell, Scott and I have been friends for a long time, and it's an absolute joy to have Scott on the podcast. So, Scott, you and I have been friends for a long time. We've talked about a lot of things. I love your thought process and your extensive experience in business and understanding. Yeah, but you do, man. You've got this.
Why do we get everywhere?
Yeah, you got this cool world view on how things are going with this. So what we'd like to talk about today is how changes in compensation in the future will affect access for patient care. So, my friend, the floor is open. Let us have it. What do you think?
I think it's such a large topic that we've got to narrow it down. I think that compensation unquestionably affects patient access because compensation unquestionably affects physician behavior. Compensation unquestionably affects medical student selection, and all of those things are inextricably bound to patient access. And so I think that if you're going to have a conversation on this topic, there needs to be more specificity in the question so that we can get to a more specific answer if an answer exists.
Yeah, that's fair. That's very fair. So in my world, in my old private practice world, the big thing was how Medicare goes, so goes the rest of the country. So let's start with that. Orthopedic surgeons have been advocating in front of Congress for years at the National Orthopedic Leadership Conference, saying that Medicare cuts will limit access to patients. You want to start there?
Yeah, I'm sure. I will push back against most orthopedic surgeons and say that Medicare cuts don't limit or create access.
Right.
Physicians limit or create access.
Right.
And so to submit that a Medicare cut would limit access is to say in a backhanded way that Medicare cuts will change our behavior and change what we offer for the total joints. And I by no means would ever suggest that those changes aren't necessary. Those changes aren't good changes. I think that is a statement of quality. It is to submit, however, that it is a statement of quantity. And the change is because of the behavior of the physicians, not necessarily because of the cut. Again, neither good nor bad.
Right. But I could see in some cases the federal government perhaps, I hate to use the word rationing, but I know many folks who would rationing healthcare, because currently many times the incentive to do, for instance, a total knee, total hip arthroplasty is you're incentivized to do it. There's not much financial incentive to find alternative methods of helping a person treat their pain. So if you were in charge of HHS, or if you saw the way that the federal government was moving, is there any thoughts on where do you think this might go in the future in terms of the best financial methods to kind of restrain the ever increasing cost of healthcare?
So I think that one of the things that healthcare suffers from is the inevitability of rationing.
Right.
And so I think that one of the biggest problems that we have in healthcare is the same ills that many of our facets of society suffers from, and that's the inability to state the obvious. And the obvious is that human nature is such that we are greedy. And so I tell my residents all the time, if you ever get the Bible, the Quran, atheists and psychiatrists and psychologists to agree on something, then you can pretty much take that to the bank. And all of those things agree that the human beings are greedy at its core. If left to our own devices, we will overconsume. That's just what we do.
Right.
Where we are balanced is if that consumption is only as the result of something that we do, or if there is pain associated with that consumption. Then you will consume to the point of pain. Pain intolerant is probably the better way to say that. And that's what a free market is based on, right? So you will consume up until the point of pain of the wallet stops your consumption. The funny thing about healthcare is that we somehow hold it on some differing pedestal, and we completely disjoin the consumption from the pain of that consumption. Well, if we don't self-impose that pain, i.e., it hurts to pay for something, then someone else has to self-impose or has to impose that pain, rather. And that's extra imposition is called rationing. Someone else has to say you have to stop consuming. Because again, the human being is going to consume greater than they need. So all of that is a very long-winded way to say that I don't think anything is going to ever make healthcare better, because we will never have the courage to join together healthcare consumption and healthcare payment. And until that happens, you're never going to have a system that works, and you're always going to have to ration.
So, like, what about the capitated models that we have across the country that seem to incentivize all of us, surgeons specifically, to say, yeah, do the surgery where it's absolutely indicated for the best for the patient outcome, and they're incentivized to do that, but they're also incentivized not to overutilize?
I would submit to you that to do the best for the patient with an asterisk, there is a never-ending desire, in my very humble opinion, to minimize physician lifestyle, physician comp, physician all of those things, and we insert into the conversation where those things should be inserted, we insert, open quote, for the best interest of the patient. Right. And I'm not really sure that we should do that, whereas we should just be honest and say it is for the interest of the patient. However, we are human beings, and there's a part of us that you have to respect in terms of lifestyle, time in the hospital, et cetera, et cetera. The other thing I would submit is that with capitation, all you're doing, in my very humble opinion, again, is you are decentralizing the rationalization, or the rationing rather. You are changing the rationing from Medicare to each individual physician. So in a capitated model, the physician or the healthcare system is the end or the residual claimant. You get what's left over. And the idea is that you will therefore regulate all of the steps prior to you more efficiently in order to maintain what's left over for you.
Right.
Well, that is rationing on an individual basis. Now, it's rationing for individuals who have a lot, but make no mistake about the fact that even in that model, there is going to be some gamesmanship played in order to maximize what the residual claimant has, i.e. physicians, because again, we are all plagued by the terrible word, which I don't think is terrible, greed. I think it's just human nature.
Okay. I think, yeah, I totally get where you're going there. That makes perfect sense. Let's, if you don't mind, let's flip to bundles. So we know, and I'm sure, y'all CJR State? I can't remember. Do y'all have CJR over in Greenville?
I don't know what CJR is.
The comprehensive joint replacement bundle.
Oh, yeah. Yes.
Yeah.
To some degree, I'm not well versed in it since I don't do total joints, but
Right.
our total joint surgeon, we have one in particular who is, I think he is nothing short of brilliant in his ability to navigate all of those things.
So we have really two federal bundles. We've had, at least when I was council chair, CJR and BPCI, and then of course went to BPCI Advanced and all that silliness. So those are all procedural based bundles.
Mm-hmm.
But an interesting caveat on that is what Carl Koenig and Kevin Bosick are doing in Austin, where they're going more on a diagnosis based bundle of knee pain. So they sell the bundle at knee pain and they treat it that way. So they take care of this capitated group of folks for knee pain rather than a capitated group of folks for a total knee arthroplasty. Thoughts on that? Thoughts on how that can affect access or affect the ability for patients to get care?
I think short of having patients pay for their own procedure, and I personally think you didn't ask this, but I personally think there needs to be a 401k of healthcare that government, employers, and patients all fund, that is portable, goes with the patient, and that's how healthcare is funded. But that's a whole different conversation. Based on what you're saying, I personally like bundles. For every dollar in healthcare, someone is going to consume every penny of that dollar. Right. Someone is going to. And going to a lot of individuals who don't directly access or affect, rather, the delivery of that healthcare, the quality of that healthcare, or the outcomes of that healthcare. I think that with a bundled payment, because, again, what is bundled payment? What are capitated models? It is rationing at the local level. With a bundled payment, it at least gives the decision rights, if you will, to the individuals that are most impacted by those decisions. And I would imagine that most bundled payment systems are constructed by not only orthopedic surgeons, but also other healthcare delivery individuals that are a part of that supply chain. My assumption is that that's the case. The therapists add, the anesthesia people add, in terms of whether or not it's general versus regional versus post-operative injections, et cetera, et cetera. Everyone has a part. Everyone contributes in order to maximize efficiency. And oh, by the way, I don't know the literature as well as you do, but I would venture a guess that the literature would support that the outcomes are better. So I think it's a win-win, and it is a very good alternative to current system, and I bet will show success as more and more people become savvy on how to construct the system to do the bundle.
Gotcha. Yeah, I understand. And there's been a lot of thoughts about that, of cherry picking and lemon dropping specifically with BPCI and CJR. Well, CJR was harder because it was all inclusive, but with BPCI, when we were doing BPCI, you could seriously cherry pick and lemon drop like crazy to make sure that you packed your bundle with the folks that would be the most likely to be able to do very well on it. And so,
you don't want a bundle buster. You can't have a bundle buster.
But isn't that affecting the access then? What about the poor folks that are the lemons? What do they do?
So you can look at this one of two ways, or one of many ways, I bet. If I own the bundle and I'm the residual claimant, I don't want bundle busters.
Right.
I don't want bundle busters. And quite honestly, for every bundle buster that is out there, I would bet for the amount of time it would take to do the total knee and the BMI of 55 or the revision or the whatever, I could make the argument that I am taking 2 to 3 of the skinny, well-insured tennis playing total knees off of the list of people that need a total knee. So I could make the argument that I am doing what I can to help society benevolently, because I am helping the skinny, well-insured tennis player get off that list. I could also make the argument that in my doing so, I am also freeing up space, because I'm generally going to do that at my surgery center. I'm not going to do that at the level 1 trauma center. I'm not going to do that at the what we call the big house. I am freeing up space in those areas to deal with the 55 BMI uninsured people that also need total joints. So I am helping access. I am freeing up space for those individuals to get their need done. So on the flip side, though, is the hospital, who may see it another way, but in the absolute sense, it is the most efficient way to do things.
Okay. So in South Carolina, or if you feel so inclined, you can comment on it nationally. What about what the federal government has done under both administrations, both under Trump and Biden, in their healthcare plans that have helped or hurt access to underrepresented populations? Is this the wave of the future? Have we learned anything from this, or is this once again just more political garbage that goes on inside the Beltway that really just helps people get elected and really doesn't help the poor people in need?
So I don't know of anything in particular that they've done. I'm not versed enough to say that there are facts of either side's healthcare plans that specifically affect or not affect minorities, impoverished minorities. I don't know, with the exception of the arguments that people got into back in the day about Medicaid and whether or not Medicaid should expand under the Affordable Care Act.
Right.
And those were conversations that were, I quite honestly think, above the pay grade of many physicians, though we were never at a loss of wading into that minefield. And it's certainly above my pay grade to determine whether or not states fared better with or without accepting that money, whether or not physicians fared better accepting that money. I would submit that both states and physicians, neither of them are monoliths, and there are going to be certain segments of the state that did well and certain segments that didn't. There are going to be certain physicians that do well under an expanded Medicaid system and certain physicians that won't. But I don't know enough about the particulars, unless there's a specific question, to say that Black folk, as an example, do better than non-Black folk under Trump or under Biden or under Obama or under Bush or under Clinton or under Bush or under Reagan or under Carter. I mean, this stuff has been going on since the beginning.
Good job. Rolling it back. All right, let's by the way, I don't know, did South Carolina expand? Did Nikki Haley expand y'all, or do y'all stay?
No,
I didn't think you did. Yeah,
I don't think we did. I mean, that's going back some years, but I don't think we did.
Yeah, I left a non-expansion state and moved to an expansion state, Georgia to Pennsylvania.
You went all in on your move. You went all in.
And here I am, my friend. Let's talk about the private payers, because correct me if I'm wrong, but didn't you and George talk about it one time, getting into the insurance game?
Yeah, we did. When the Affordable Care Act was created, there was a little provision in there about expanding insurance coverage by providing grants to insurance companies that would insure the marginally insurable.
Right.
Generally, fiscally speaking. So we several of us, when we were at Kellogg, this is now 12, 13 years ago, thought we would give it a go and try to make this insurance company. And it was a very expensive lesson, since we all had to come up with the money for the actuarial review. It was a very expensive lesson that taught me more than Kellogg did for about the same amount of money in terms of tuition. So we did start that, and I don't know, the private payers, this whole system is so screwy. The fact that your insurance is largely based on your employer and not based on you, creating tremendous incentives to serve or behave a certain way that I'm not certain serves the best interest of the patient versus the best interest of the employer. It is such a screwy system. You gotta love American ingenuity and the way in which this system has evolved versus the systems of Europe and the democracies that exist within Asia. So I don't know the answer. I don't know the answer, sadly.
All right. Well, with the private payers and with your experience with them, and also the consolidation in the market, which you know a significant amount about in terms of how consolidation affects markets, what do you see in the future, perhaps, of how changes in the private payers, Blue Cross, Aetna, United, et al., and or the consolidation of the private payers may affect patient access and basically patient care, what's best for the patient as we proceed in the future? Of course, the big scare is, oh my gosh, if we don't do something, we're going to be a single payer nation. So thoughts?
Yeah, that's the interesting thing that I wonder the most about, right? The natural push or movement away from entropy or disorganization towards organization. And so what happens when an insurance company gets a significant share of the market and doesn't want to play ball, doesn't want to do the song and dance that everyone knows exists, where systems overly charge those that can pay in order to cover those that cannot, right? So at what point does the insurance company say, I'm done with that game? And what happens if the insurance company says that and they're the biggest dog in the market? They're the biggest dog in the yard. I think that can be amazingly disruptive and scary for both sides. Scary from the patient perspective, because what do they do when they all of a sudden find their loved healthcare provider team out of network? And you might say, well, you can just go and establish a new team. And I would submit that is the answer, right? But what if it's pregnancy? What if it's cancer? What if it's something that's ongoing? And then you can say, well, you can just submit a waiver or do whatever it takes to get a carve out. And then I would submit, but man, aren't we inserting a whole lot of costs into a system by doing all of that? And you could say, well, yeah, but that's just the way it goes. Well, but then what about the patient who, because remember, we're doing all of this for the patients. That's what everyone always says, right? So we're doing all of this for the patients.
Right.
Patient-centered. Patient-centered care. So what about the patient who is now faced with the only healthcare provider in town who no longer accepts this hypothetical juggernaut third-party payer? So now this patient has to go to the neighboring town. Well, if you're in Massachusetts, that neighboring town may only be 5 minutes up the road. And you know how us in the South, everything is up the road or down the road. So that healthcare system may be in the neighboring community.
Right.
But you also remember from your time in Georgia, having a vehicle or public transportation is a luxury. It's not a right.
Right.
So what happens to that patient who now has to catch rides to this neighboring community, or up the road, as we say. I think that there are ramifications that we do not want to see, that we so quickly label as unforeseen circumstances, when in actuality, they're very foreseen. Now, they may not be foreseen by individuals who are at the upper income level and who have forgotten what it's like to scrape by and to balance their bills based upon whatever check comes in that month. But those individuals exist. And I would submit to you that it's not an insignificant part of the population. The majority of us, majority being defined as 50% plus, the majority of us will be okay.
Right.
But there are a significant number of individuals who are not going to be okay. The working poor, as an example. I don't think that they're going to be okay.
Right.
Our family gets inconvenienced. My kids had to see a new pediatrician. It killed us to leave our pediatrician, but it's an inconvenience. It's an inconvenience. My wife just has to put a little more gas in the Tahoe to get to wherever she's going. You know what I mean?
Right. Yeah. Well, that's very, very interesting. You're blowing my mind here. So what compensation models do you see flourishing in the future? Or is bundles going to make it? Are they going to drop off? Is capitation going to make it? Is there something else out there? And how's that affect access?
I don't know, Doug. That's a great question, man. And until you can put into the same vessel the consumer and the customer, the person consuming the healthcare and the person paying for the healthcare, we are going to be trying to solve this problem for the rest of time until single payer, which Lord knows what would happen with that. The single payer folks out there, I chuckle when people bring up single payers, and they love to bring up Britain and Canada. But having known individuals who have trained in like the Seattles and the Michigans, we both have, if it wasn't for the United States as a pop-off valve, the single payer system of Canada would fall apart.
Right.
I mean, the rich people just go across the border and they just pay the U.S. I mean, we all have these conversations and we retreat to our respective corners, and no one tries to actually figure out, I think, my humble opinion, no one tries to actually figure out the answer. And I don't know what the answer is. I do know that whatever you do is going to affect access. It's an impossibility to not affect access. Now, we can debate whose access. We can debate which segment of the patient population will be affected the most. We can debate all of those things. But I think it's a futile debate to debate if access will change. I think that we should spend that time debating what access will change. And if we're okay with the change, then go ahead. If we're not, then we've got to figure out what it is that we can do to mitigate the things that we don't like.
When I was in business school, we learned about all the developed world healthcare systems. And the one that I was the most attracted to was the German healthcare system. They have well over 100 insurance companies in Germany, but they're all not-for-profit. Thoughts?
Not-for-profit is not a vow of poverty.
Yeah.
So just because you're not-for-profit doesn't mean to me anything. Because if you look at, aren't the Blues not-for-profit?
You're off my head there, brother.
I believe that the Blues are. I don't know, but
not sure. They seem like they're trying to make money.
One of your listeners can email us and tell us how wrong we are, but I think that the Blues are not-for-profit. There are many not-for-profits out there that have CEOs that are making 8 figures.
Right.
Not-for-profit is not a vow of poverty. It just means that you don't have shareholders and that you call profit something different. And so having 100 not-for-profits to me doesn't change the problem. It just changes the name of profits, and it just changes who it is that gets paid. But it doesn't change anything about the patients. I think, and you and I did B school years ago, and I remember a case that, isn't it Singapore that has almost akin to a healthcare 401k.
Right. I believe so.
It's not that I came up with this on my own. I want to say it's Singapore, and it completely makes sense to me. The amount of money that we put into Medicare per person, and obviously you can't do away with Medicare and blah, blah, blah. I get all that. You can't have an immediate conversion, but just think about this. If there was a way that we could fund a healthcare account that is owned by the patient, and the regulation is that you have to spend it on healthcare things, and the healthcare account is funded by the government at first, and then you have the ability to fund this healthcare account pre-tax dollars for the rest of your life. And there are a couple of caveats that you have to put into this. Number one, it can be transferable. You can will it to your heirs, to descendants. You can will it to individuals that aren't related to you. You can gift it to healthcare systems that can in turn gift it to patients. So these are accounts that are wholly owned and managed by the citizens. The other thing, people will push back and say, well, the poor. If you look at the data, the number of individuals who are in abject poverty and stay in abject poverty, it's actually it's a small percentage. The number that bounce back and forth between low income and poverty is a greater percentage. And so at some point, most individuals would fund this account to some degree. And again, you've got a system of benevolent people that can do this, that, and the other. The other thing that I think you would then need, and I thought about this entirely too much back when I was in B school and I was reading books and I was thinking how I could solve the world. The other thing that you would need is real healthcare insurance. What we have now is not healthcare insurance. We have healthcare prepayment, right? Insurance is something that is a hedge against an event that is unlikely to occur. Because if it's likely to occur, then you prepay it. You don't get insurance, right? So car insurance, home insurance is even a better example. The chances of your home going up in flames, it's very little, knock on wood. It's very little. The other thing that you need with insurance is an agreeable value before the event occurs. Again, you go to your insurance company and we agree, this is the value of the policy. This is the value of my home. The other thing that you need is the risk of the event has to be spread amongst a like community. All of the houses on your block, as an example. These are the reasons why flood insurance policies are so difficult to come by. Because if it floods, it affects all of the homes. You can't mitigate the risk.
Right.
It doesn't affect just one home. So you need all of those things for insurance. And so with my crazy healthcare plan, the other thing that I would say is all of the Blues and the Aetnas and everybody else get into the real insurance game. Go to individuals and say, we've got policies that are worth X, Y, Z, A, B, C, D. These are what the premiums are. These are what the policies cover. And people would select policies based upon the amount of money that they have in their healthcare 401ks. I think that is a very interesting way to solve healthcare, but no one will do it because there are too many people making too much money in the current healthcare system to ever change it.
Very interesting. I was going to ask you, if we made you Secretary of Health and Human Services for life, no president or Congress could kick you out, what would you do? And I think we just heard it, right?
I would get assassinated. Is probably what I I would make so many people upset. I would have to wear a bulletproof vest. But
I'd work for you. It'd be entertaining, man.
But yeah, I would figure that out, and I would bet money that there are dollar amounts that you can calculate Medicare expenditures between the ages of 55, 65, 65, 75, 75, 85, 85, 95. We can figure it out. We can preload those individuals' healthcare accounts with whatever the dollar amount is. Every child born in this country will get a healthcare dollar amount of, figure it out, whatever it is.
Right.
You know, as well as I do, one of the greatest inventions in human history is compound interest. So that newborn, when you put X amount of dollars in there, in theory, if that newborn gets to our age before needing something of any significance, there is going to be so much money in that newborn's account, it's not even funny. And all the while, that newborn has access to regular insurance to cover the catastrophic things. The most critical part of all of this, which is taking advantage of human nature, is this. And push back if you wish, but feel what I'm telling you. It would take no more than a generation before healthcare delivery systems would understand that individuals are coming with cash and begin to compete for those individuals, just like car manufacturers compete, just like clothing manufacturers compete, just like everyone competes.
Right.
The individual would all of a sudden become a savvy consumer, a savvy shopper. Gone, not immediately, but quickly, gone would be the, I need an MRI and no other questions are asked.
Right, right.
You would get an MRI, or you would order an MRI as a physician, and the patient would say, whoa, doc, how much is that going to cost? Now, they may say that right now, but all of us say, I don't know, a couple $1,000. And the patient goes off because the patient doesn't have the pain of paying that. If it's coming out of that patient's healthcare 401k, like, oh, doc, you need to give me a little bit more than I don't know. Because I know what I've got in my 401k, and I need to know how much of a hit this is going to be.
Right, right.
It wouldn't take very long at all. I liken it to the tokens of orthopedic match system now. It's taken, 2 cycles before, exactly. Yeah, people have realized, like, oh, wait a minute, this is a valuable resource. These tokens are valuable. And on the flip side, we as programs have realized.
You're talking about signals, right? Signals?
Yeah. These signals are valuable. We can utilize human nature to benefit human nature if we are intentional about it.
That's fascinating. Now, you were getting into this a minute ago, but there's been a number of studies that show that, half of the healthcare dollars most people spend in their entire lives are spent within the last 30 to 90 days of life.
It's something. It's insane, right? It's something like that. And out of that half, how much of it changes the final outcome?
Right.
Right.
Exactly.
It is insane. And if heirs and others knew, because the majority of time, the people that are making those decisions aren't the patients, because the patients are intubated, they're out of it, they're whatever. It's the descendants.
Right.
And it's not to say that we would want to wheel grandma off the cliff or whatever the fearmongers say. It's not to say that at all. It is to recognize that if you're sitting there, I just went through this with my own mom when she passed in October.
Right.
We are sitting there with end stage issues versus the ability to continue to do more. The risk benefit conversation at some point leads to the decision, it's been enough. We would be much more likely to have that conversation if the family realized at the end of this, within mama's will or grandma, big mama's will or whatever, she's left whatever money to your healthcare 401ks. It's a much more readily approached conversation than it is right now, because there's value to the other side of the conversation, whereas right now there's just sorrow.
Right.
I really believe that to be the case.
And to your point, that could certainly maintain and improve access in the future and other things, and continue for wise expenditure of the healthcare dollar rather than a lot of the foolish.
Yeah. I mean, we'd have to work through the details, and you'd have to get a whole bunch of people. What's covered? What's not covered? Who can have access? There are a lot of questions, but the concept is one that I find enjoyable.
Very good. Well, I hope you all have enjoyed this as much as I have. We've had the pleasure of talking with Dr. Scott Porter on how changes in compensation will affect access for patients to have healthcare in the future. Scott, thanks so much for being on the podcast.
Thank you so much. It's always good to see you, man.
Yeah, buddy. And we look forward to future topics on this AOA podcast series. Thank you.